Hi, class. We're going to begin a discussion of treatment. I suppose, in the larger sense, we should say management of pediatric swallowing and feeding disorders. You will hear both terms, treatment and management, used. I do like management better because it includes a greater variety of services, including medical procedures, deferred treatment, referrals, etc. So let's go ahead and begin. And you'll probably have come to the same conclusion that I have when you looked at your textbook. That is, that there are lots and lots of different treatment approaches. What I thought I'd do in this lecture is talk about several themes for intervention that seem to allow us to think about these techniques and procedures and group them by idea rather than just thinking about them as randomized lists of tasks. So the themes that seem to me to be evident when thinking about intervention or management with the very young cases of pediatric swallowing feeding disorders would be, I think, topped by this first recommendation here. That is, our primary purpose here is to help make sure that the newborn is getting sufficient nutrition for development in general, but specifically for the developing brain. If there is not sufficient nutrition at this stage, then there will be abnormal development of the CNS, and so it is really our primary purpose to make sure that that takes place. That might mean oral feeding and working towards oral feeding, and it might mean that non-PO methodology is what's called for. A second big topic to think about is the idea of trying to take oral motor skills and oral motor function, which may not be at developmentally appropriate levels, and normalize the ability of the infant in these areas. So premature infants, neurologically damaged infants often come to NICU and do not have the oral motor skills that a newborn might need to get enough nutrition in those first crucial days. A third topic would be muscle condition, tonicity, so either too much tonicity or too little tonicity of the muscles, and the ability of the muscles, along with the skeleton, to help stabilize the torso and the neck and the head so that the infant can take part in feeding activities. A fourth category would be that of sensory responses on the part of the infant. Newborns have these reflexes that allow them to have quick and rapid responses to environmental stimuli. So they have a startle reflex in response to a loud noise. They have a rooting reflex in response to sensory input, touching on the cheek, and so on. Sometimes premature infants do not have these same sensory responses. In fact, they may be hypersensitive to various kinds of stimuli, including oral stimuli, and they need to have sufficient regulation of their sensory response so that they can attach to a nipple. Final theme would be the all-important coordination of respiration and swallowing. This is a theme that I'm sure that you have already committed to memory. It is nevertheless a huge part of what we need to take into account as we're planning intervention for neonates. In case it wasn't clear, this first lecture is about our youngest clients and their treatment or management. In the second lecture on treatment, we will discuss older children and eventually discuss adolescents. Okay, so we're going to consider each of these sort of themes as we work our way through, what are the techniques that are needed to help guide a newborn towards more appropriate and efficient eating and swallowing skills. So the first theme we're not really going to talk that much about. That was the theme of safe and effective nutrition and hydration. I think that we have that one down, and so I sort of grouped it underneath this bigger topic of, sufficient nutrition for the developing brain. There's a great quote by Joan Arvidson, and I believe that actually is a typo, Arvidson. She's a pretty famous author in the area of pediatric swallowing and feeding. And her quote that reminds us about our goals in those early days is that she's talking about early intervention, and she's saying oral feeding becomes a byproduct and not a major goal of your intervention. So because we want to make sure that that infant is getting enough nutrition, we may be focusing on improving the skills that they need eventually to succeed with oral intake at the same time while they are getting their nutrition in a non-oral manner. Now, it's important to remember that non-oral feedings don't mean that there's really nothing for us to do with a child who is getting his nutrition in that way. We can help the parents bond with the child. We can help establish non-nutritive sucking. We can stimulate oral motor skills. There's a variety of things we can do even with the child who is not yet ready for oral intake. The theme of normalization of oral motor function is another one that's very important for our youngest clients. This again reinforces that idea that we're not always doing feeding therapy per se, not always doing work on the exact moment of intake. We may be working on other skills that are necessary for their success with eventual oral intake. So that could be coordination of movements. It could be include exercises, but it also can include some indirect kinds of techniques such as oral stimulation. That would be cheek tapping or tapping the tongue. Also positioning can be used to facilitate appropriate oral motor skills. You can use a variety of different structures in stimulating oral motor development, and you may know about some of those if you have worked with children who have cerebral palsy. So these are chewy toys where they can get oral stimulation by mouthing or chewing on different kinds of things. With newborns, you can use a rough cloth, you can use a finger, you can use a toothette. These days in a hospital, typically I will use a toothette because I want to make sure not to introduce anything into the infant's mouth that is not as clean as possible. If the baby has a pacifier that the parents have been using, then I will use that also. An author that I mentioned earlier, Joan Arvidson, talks about stimulating oral development by using rhythmic sort of tapping and stroking. So she will talk about rhythmically brushing the tongue once or twice per second, 4, 5, 6 times. And on the 6th time, to press slightly firmly before withdrawing the stimulus item. And evidently in her work, this sometimes will stimulate the infant to attend to the stimulus on the tongue and to curl their tongue or to protrude their tongue, almost as if they have awareness of that structure. The idea of tonicity of muscles and stability of structures is also very important for our neonates. This too could include positioning, as we just talked about. It might also mean providing support for weakened structures. So these are going to be some of the techniques that are mentioned in your textbook and that are mentioned in the list of techniques to emphasize for the class. Things like using your fingers to provide chin or lip support or jaw or cheek support as the infant is sucking. We want the infant to grow and develop and to take in enough PO that they can thrive, such that then we can work on facilitating development of better tone throughout. Likewise, infants can be positioned so that issues with tonicity and stability are somewhat minimized. So you will see nurses who help infants to be positioned in a somewhat upright position so that you're holding the baby perhaps in one arm and you're supporting the head, but you're not cuddling the entire torso. You're challenging the muscles of the torso to provide stability and facilitate the correct position. Likewise, infants who are hypertonic, have too much tonicity, seem to do better when they're in slight flexion. So sometimes abnormal tone, abnormal reflexes can be minimized if there's just a little bit of neck flexion. So again, the infant could be held in one arm with the head slightly curved towards the chest. So it's similar to the chin down position that we might use as a positioning technique with adults, but it's not quite as extreme as that. Working on tonicity, again, you could do direct exercises that are going to encourage use of structures. But these indirect techniques with the very young seem to be the most beneficial because, again, what is our goal? It is to get the infant, to take in enough nutrition. We have mentioned the theme of trying to elicit appropriate sensory responses. So sometimes infants who are hypersensitive can demonstrate what is called an oral aversion, so that when you approach them with a nipple, they turn their head away. And as you can imagine, this makes getting enough nutrition pretty challenging. One of the techniques that's suggested in the literature is by stimulating the baby from the inside out to lessen their reaction to oral stim. So it might be that you stimulate them and you encourage them, you use a cloth or a gloved finger or a nipple, and stimulate the outside of their cheeks and the exterior part of the oral cavity, so the lips. And when they do not react anymore to that kind of stimulation, then you stimulate inside the oral cavity. Another technique that's suggested for reducing abnormal sensory responses is to encourage non-nutritive sucking. Now, non-nutritive sucking is beneficial for so many reasons. Again, this is sucking activity that does not deliver nutrition. So it would be sucking on a finger or sucking on a pacifier. It is to help the infant to learn to essentially calm and regulate their own responses. And they learn to associate sort of this sucking behavior not only with food, but also with calming themselves. And over time, use of non-nutritive sucking, NNS, then has been shown to also help infants who have inappropriate sensory responses. In NICU, as you may recall, there were lots and lots of bright lights and people coming and going. But in the photo that I showed you, they had draped baby blankets over the tops of the isolettes so that the light wasn't shining directly into the baby's eyes. And this is part of recognizing that super bright lights and lots of noise and commotion does not necessarily encourage newborns, especially those who might have abnormal sensory responses, to develop appropriate feeding behaviors and to develop in general. So if the baby that you are seeing for treatment is an outpatient or is in a private clinic, you might try manipulating the environment for a child who has sort of outsize reactions to lights and noise, and have parents work with them on try to encourage feeding behaviors in a room where the overhead light is turned off, where it's quiet, and the infant is not essentially distracted. Another theme is the theme which underlies our favorite phrase, suck, swallow, breathe. So that would be the theme of coordinating respiration and swallowing. There are a number of techniques in your book that are discussed that may be helpful with this sort of coordination of these two processes. One that is mentioned is pacing. So pacing implies that the caregiver will be helping the infant to establish an appropriate intake rate. So through your evaluation, you may have noticed that the baby is able to suck once, twice, 3 times, and suck, swallow each time and breathe afterwards appropriately. But once you get into more sucks and swallows than that, then the infant may become somewhat discoordinated, may choke and cough. There are ways that you can control the flow of the liquid for babies that need help. So if you have the bottle tipped down slightly, this is with the nipple of the bottle in the baby's mouth. That will slow the flow down, and you can also select nipples that have a restricted or a slower flow for use in those very early days. A few additional points about feeding and about our neonates. One is that you will hear nursing staff talking about stress, infant stress during feeding. And the best way I find to deal with this in terms of how you're going to take this into account into your intervention program is sort of to have a 3-pronged idea about it. That would be, okay, how do I know that they might be stressed? That would be the behavior. Then, what do I think is causing that behavior or that stress? And again, it might mean stress in the psychological sense, but it might also mean physiologic stress. So I would identify the behavior, what's causing the stress. what behavior am I worried about, then the cause of the stress, so that again, psychological, or in a very young baby, it's probably going to be physiologic, and then to brainstorm about the solution. So I have 3 different scenarios here for us to consider. So let's say you're in NICU and you're feeding an infant, and the baby does fine for a few suck, swallow, breathe cycles, and then you notice that the baby starts to drool a little bit, or gulp, or cough, and at that point, then you're going to start to think, okay, this baby seems a little stressed, at least in the sense we're using it in NICU. What do I think is causing that kind of stress behavior? And in this case, I would suspect loss of control over the bolus, either because the bolus is too big, or it's coming too quickly, or because the baby is fatiguing and isn't quite as coordinated. Okay, if that's the case, then what will my third prong be? Well, there are a number of different solutions to this particular stress behavior, and they happen to be ones that I just mentioned. So perhaps slowing the flow of the liquid by lowering the bottle once the nipple is in the baby's mouth, or by pacing. That would mean, for example, in this case, allowing 3 suck swallows and then perhaps removing the bottle. And then repeating again, 3 suck swallows and removing the bottle, allowing the baby to recover. A second scenario that it seems to me happens pretty quickly in NICU, and that would be you go to feed the baby, and the baby was sleepy when you got there. So you unswaddle the baby because you know from your experience that a little stimulation is perhaps going to help wake the baby up. You unswaddle the baby and brush their legs, brush their arms until they wake up a little bit, and you start feeding, and things are going well. But then the baby wants to go right back to sleep. All right, that's the behavior that tells me there's some kind of feeding stress. What do I think underlies it or is the cause? That would be, in this case, possibly just general fatigue. What could I do? Well, once a system is fatigued, the only thing that really allows it to restore is going to be rest. So we can't always or indefinitely allow for short little teeny-weeny feeding cycles because the baby won't get enough nutrition. But we might be able to, in the very beginning days, give the baby some success by then allowing them to rest and then restarting the feeding process. A third possible scenario, less common, but it still occurs, and it definitely occurs in outpatient babies. And that would be that while you're feeding the baby, a number of strange and undesirable things are happening. The baby changes color, becomes slightly blue, or the baby starts vomiting. Okay, I'm going to brainstorm now. Now, I know that blue color is going to come from desaturated blood, from blood that does not have enough oxygen in it. What could be going on? And then the baby's vomiting. It's almost as if they can't tolerate food into the esophagus, and then something bad happens. I'm wondering, so now we're to the source of the stress, if this baby has GERD. So I'm going to, that would be gastroesophageal reflux disease. I'm going to look in the chart and see if anybody else has noticed this, and I'm also going to talk to the physician. In the meantime, I'm going to try some alterations to see if the baby has more success, can stay oxygenated, and handle the intake better if I hold them slightly upright, lessening the extent to perhaps to which reflux material enters the airway. I'm going to talk to the physician about medication for GERD that will help eliminate these symptoms. And I'm also going to talk to the nutritionist or the dietitian and ask them about using the possibility of using thickened liquids, which would slow the rate down, allow better airway protection, and along with the medications, hopefully over time, lessen the symptoms of GERD and allow the baby to take in and keep the nutrition that they need. Well, you just heard me mention the nutritionist or the dietitian, and that brings us to the next topic, the last topic for this lecture. That would be the topic of using a team approach to management of pediatric swallowing and feeding disorders. I, in general, am a person who is in favor of team approaches whenever it's possible, for everything from treatment of stroke patients to neonatal feeding issues to a clinic that I worked in once as part of a team that was doing differential diagnosis on children who had attentional issues. And one of the questions at hand was, we want to make sure that there aren't any other sort of auditory processing and or language comprehension production issues that are causing the child to act out and lose attention in activities in school. So for all of those things, as well as for our neonates, a team approach is absolutely the best, not to mention it's the most fun. Who is on the team? Well, some kind of physician. So for the very young, it's going to be a neonatologist probably. For slightly older children, it will be a pediatrician or a developmental pediatrician if this is a syndromic child or a child with special needs. Or it might be a physician who is a specialist that is relevant for the child's specific medical diagnosis. So it might be a gastroenterologist for our reflux babies, might be a cardiopulmonary person for the infant who has a cardiopulmonary disease, etc. So a physician, the SLP, of course, a nursing staff. In some places, hospitals or clinics will add an OT, an occupational therapist, as well as the SLP. In some places, and specifically in some states, OTs and not SLPs are the professional of choice on the team for neonatal feeding and swallowing disorders. There should also be, if you are fortunate, a nutritionist or a dietitian so that you can consult with them, or if it's the OT who is in charge of the intake for that case, they can consult with them to determine what the methodology will be for intake, and they, the nutritionist or dietitian, will determine the number of calories that will be needed, the composition of proteins and sugars that is appropriate for the baby's age, etc. And finally, a pediatric or family care social worker is always welcome. They are extremely helpful to the family. They will be available certainly for your inpatients. Once patients are discharged, they are not always part of the picture, but whenever possible, I encourage you to find one that you feel like you can work with and include them as a member of a team. One other mention of the SLP versus OT issue, and again, in some states, the OT is the person who, if they have taken specialized courses, can be certified to assess swallowing. this is a matter of some contention for our two fields. I myself like it when we can work together because OTs have a slightly different orientation. They can help us with our older children in terms of self-help skills. They often have access to a wide variety of adaptive devices and chairs that can be extremely helpful. So I'd prefer it if we were on the team together and could work together. And when that's not possible, then I try and do as much education as possible to other professionals to let them know that this is, in fact, part of our scope of practice. So I mentioned that a team approach is the best of all possible worlds and that it's also fun. There are other reasons here why it's a good idea. I suppose best of all worlds and fun are pretty related for me, and I think this first point covers it. It's that you all of a sudden have this very, very large shared fund of knowledge, so that if you're discussing an infant who has been on gavage feeding for quite some time and about transitioning the infant to oral feeding, then you're going to be able to chime in with what you know about the importance of oral stimulation, of making sure that the baby is alert, etc. The dietitian will share their concerns and perhaps, suggest a plan of limited trial feedings while the infant adapts and gains strength. The pediatrician or the neonatologist will monitor the plans of the other professionals and make sure that they're all integrated into one treatment plan that has one goal, and that is to establish safe feeding. The social worker can help connect the family with community resources, can help them with insurance issues like getting reimbursement for adaptive utensils and special chairs. It is an approach that leads to better care for the patient and their family, and it is really fun to talk with other professionals and problem solve with them, feeling a certainty that you are covering all bases of medical care for this child. That's the end of the focus in this lecture on the neonates. In the next lecture, we will go on to talk about older babies, children, and teens, and management of their swallowing and eating problems.